Welcome back, everybody, for part 2 of Trauma Systems, looking at the mechanism of injury. Mike Hislop for Orlando Medical Institute TV. We are going to jump right in where we left off and proceed with blast injuries. And it's an unfortunate reality, and we're not always talking about some radical with an agenda. Things blow up. Hot water heaters blow up. We respond to fire scenes where obviously combustion's on the table. So blast injuries, while they may be infamous and terroristic, certainly they're not exclusive to that sort of thing. We have to understand the mechanism associated with a blast. The first thing that's going to hit us is the thing that has the least resistance and can move towards us fastest, and that's air pressure, right? That first pressure wave that's generated. And what's that going to affect more? Solid organs or hollow organs? Hollow organs, well done. Hollow organs, because they're hollow, they're more compressible. So the lungs, the eardrums, all those compressible organs. So look at the ear. Is the person having hearing deficit? Is there blood coming from the ear canal? Did we puncture those membranes? Is there petechial hemorrhaging in the eyes? These are early surveillance when we first get a look at our patient on general impression as to what's the likelihood of their injuries to come. Because if they compress those lungs under a great deal of force, they can have some rails coming in their very near future. The secondary blast injuries typically are flying debris, right? Why did they get to you second? Because more resistance coming through space and time to come at you. So that's the second thing that's going to happen. And very often, unfortunately, in our reality, people can make bombs with projectiles and things associated with them in order to create more flying debris and more projectiles in order to create maximum damage and fatalities, essentially. So the blast occurs, and then you're getting hit directly behind that, sometimes like seconds behind flying debris. And again, this can create penetrating injuries, something that may be missed by the patient completely. It's something they don't even report. So they have to really, really have that complete examination to make sure that there isn't something that we've missed. Now, the tertiary or third, that occurs when the person is hurled, right? So first that air wave, the primary, then the flying debris, and then you're pushed backwards, and you're hurled against the road, the building, the tree, the whatever stationary object. So displacement on the body, that's, again, a third hit. So 3 traumas already, right? Quaternary and or the fourth one is associated typically with heat, right? Respiratory injuries, crush injuries, the fact that you hit something and something came back on you, or a bunch of falling objects came on top of you, crush and entrapment. That's all that quaternary or extra things that can happen afterwards, associated with luck or unluck, depending on what you were near and what was near you, and how close you were in proximity to the initial blast. Biologic, chemical, radioactive stuff, it's out there, right? So people with an agenda are going to associate that with making it a dirty bomb. And anytime we add something biologically infectious, add a chemical that's particularly noxious or toxic, or add certainly radioactivity to it, it's said to be a dirty bomb. In which case, this screams this is a person with an agenda, so we have to automatically start thinking about potential for secondary devices, I'm afraid. And again, the little depiction, there's that primary blast, that primary, secondary, just a real good depiction and an ability to kind of say, what were you affected based on where you were? Maybe the pressure wave didn't hit you very much because it dissipated enough, but you were hit with flying debris from a distance. So it really depends on how close you were to that initial blast. If you're very close, obviously you're going to get all of these. And very often closer to a heat source obviously means more significant burns as well. When something's detonated, it converts a large volume of gas under pressure to now outwards, right? So it creates propellants, right? Explosives, up to include something that's even already under compression, like a BLEVE, right? A boiling liquid expanding vapor explosion, right? Something where it's liquid that's under heat in a non-compressible tank, in which case they're designed to release energy, some slowly, some quite quickly, depending on how high velocity or high impact they are. Leading edge, again, is the blast wave. Little review, pulse wave, higher atmospheric pressures, it's going to move it through more quickly because it's less resistance. You have that shock wave with high explosives, right? So these are your TNTs or some high things. And negative wave pressure where it actually can blow outward and actually create a pull afterwards. And a lot of times there's actually bombs designed for biocontainment where you can actually blow in where it pulls air into the explosion versus the opposite. But those are made by design that way. Speed, duration, pressure of the shock wave, what kind of extent, that's all going to go into the physics of it. How much how much of an explosive charge was there. If you have an open hand with a firecracker going on, you may have some small amount of charring. But if you close your hand around that same firecracker, you're probably going to lose some digits, right? So it really comes down to, was it in an enclosed environment that now added to the explosive force? And very often these are all things that we have to kind of get an early indicator of as to mechanism of injury prediction. And really it comes down to, in trauma, that's the big key. And can you predict the amount of force, where it went, and how it was dissipated? And those are going to be those big variables that are going to make you really, really good at surveillance. Closed spaces, obviously, the pressure wave inside someplace, if you're in a room or a building or a fixed amount of space versus an outdoor thing, obviously that's going to increase the modality of death and dismemberment in a closed space where you're now confining that pressure wave. And obviously outcomes are going to be significantly worse there. Tissue at risk, we know the air-containing stuff first, right? Stomach, lungs, eardrums. Your eyes are under pressure, right? So you're gonna have that petechial stuff that I talked about. Lots of GI stuff, right? The intestines are completely, so if you have a full bladder and you get hit by the big airwave, it's not uncommon to evacuate. If you have a full intestinal tract full of lunch, and in which case you're going to have that. But remember, the ear is the most sensitive. That's where I always start my surveillance, right? Look at their eyes, have them turn and look. Can they hear you properly? Is there blood or fluid in the ear? It's going to let you know, because if this is the most sensitive and it wasn't affected, it stands to reason the less vulnerable organs likely don't have significant issues as well. But again, good auscultation and good surveillance of those lung fields. You start to have the pulmonary hemorrhages and pulmonary contusions. It can actually start out sounding pretty benign and get much, much worse pretty quickly. So we have to keep in mind, surveil for those pneumothoraces and hemothoraxes associated with that large pressure wave, as well as we have to get a real good look to make sure we're not missing penetrating trauma that's associated with as well. Get them oxygen, but really just keep in mind, we're looking for that digression in their respiratory status over time, because that can happen in that 10-minute, 12-minute, 15-minute, even up to an hour later. Suddenly they're in acute distress based on a lung injury they got sometime before. Solid organs, if they're injured, it's going to be when you're hurled, the sudden stop certainly can do it. The amount of concussive force can certainly fracture because they're non-compressible when they're highly vascular like that. Neuro and head trauma is the most common cause of death. Obviously, your brain is in a finite amount of space. So if your skull remains intact, it's a detriment. Obviously, if that protection is broken, well, that's a detriment too. So either way, you really have the ability to kind of bleed intracerebrally or to get that subdural or subarachnoid bleeds. And very often, these are going to be the causality of mortality there. Extremities, obviously, they're easy to kind of break extremities. We know how to do that. We do it pretty often. But they're rarely life-threatening, in which case it kind of falls to that triage kind of thinking. Assessment and management. First and foremost, seeing safety, seeing safety, seeing safety. Not just of what has happened, but what is in the future, right? Very, very often, we are getting better and better and better at being smarter about our responses, right? So you have to assess for other hazards. Is it a dirty issue? Is it a secondary device issue? Is this something that was an accidental detonation, a blast of an accident versus something that was by design? So you got to get that feeling, get that general impression, and again, rely on law enforcement a little bit to kind of make scenes safe for us. There's no such thing as a job without risk, but IQ can mitigate a great deal of it. Breath sounds frequently, as I said, because the lungs obviously are highly at risk for a lot of this stuff. Look for all your abnormalities on your exterior traumature. Look at that baseline SaO2 with that amount of oxygen. If you find that digressing, it's a good indicator that we have an issue, right? And certainly what your patient tells you. Are you having more or more difficulty breathing? And certainly ask. Absence of abdominal injury based on the absence of covert signs. In other words, if we're not seeing trauma, we're not seeing bruising, that doesn't mean you didn't fracture your spleen or liver or one of the great vessels in your abdomen or chest. It didn't show you anything up front, and it won't until the pain starts increasing. You start seeing ecchymosis, or maybe better, you start just seeing that tachycardia and that blood pressure is falling out. You're starting to go into stage 2 shock, in which case you have to keep a real close eye on that. Obviously, keep yourself safe first and foremost. You got to wear your PPE. There's flying debris, there's hazards, there's falling debris. This is a bad environment. So obviously, if you have firefighter personnel with be bunkered out completely, right? And have your own air source if possible. Anticipate and get ahead of scene hazards, right? Electrical, flooding, gas lines may be exposed. You may be leaking natural gas. Everything's on the table here, especially with a structural explosion. Assess your environment carefully, move forward carefully. Rushing in sometimes can be done so at your own peril. This is really one of those really kind of, you got to surveil your scene quite closely. Secondarily, primary survey doesn't change a great deal. What you're looking for specifically with those ears and eyes and things like that, certainly that counts. Spinal immobilization, obviously in big trauma, has to be on the table and it has to be considered, and very often may be completely appropriate depending on what happened to your patient and how they were found. Use your AVPU, certainly, alert, verbal, pain responsive, unresponsive. Talk to them, get them breathing, get them talking to you. Jaw thrust maneuver is going to be indicated, not head, tilt, chin lift, obviously, if spinal immobilization comes there. Anything in the airway, get it out. Aspiration precaution for people with altered mental status is always paramount to our thought processes. Consider oral NPA if there's no head trauma. If there's facial or head trauma, NPA, again, contraindicated. So we have to use what we know, even all the way back. Really good trauma outcomes sometimes come back to having really good EMT skills. Airway and breathing, patients unresponsive, obviously, get them breathing. Airway's clear, assess your breathing, deal with the airway, right? Can they maintain their own secretions? Do they have a gag reflex? If they're completely unresponsive, they take the OPA, let's definitively take care of that airway. But in the meantime, let's make sure that we're getting good tidal volume, right? We're not going to build up atelectasis. People with broken ribs tend to splint. They take little tiny breaths, in which case, notice that the patient is tachypnic and under a little distress, and certainly orthopedic injuries can be at the realm of that. So are they speaking to you calmly, and can they make complete sentences, or are they in some level of distress? Obviously, these people are going to be anxious, in pain, afraid. All of those things are appropriate. But we have to keep a real good eye on that sort of thing. Look for that. Look for that quick skin color, right? Telling you about perfusion. Trachea is midline. Good. I got bilateral breath sounds. I don't have a tension pneumo developing. I'm going to have to reassess that. I'm going to check the neck. Is there crepitus? Do I have broken ribs that potentially are going to cause that pneumo? Is my sternal intact, right? Do I have that reciprocal movement or crepitus on the sternum? All of these things are on the table with high explosives, and certainly with other things that can inhibit breathing, even diaphragmatic injuries. Circulation is all about hemorrhage, right? If you can't stop external bleeding, typically they're going to run out. So up to including even a tourniquet early. If there's no radial pulse, do compressions. The likelihood of you having a good outcome is quite low, unfortunately. Trauma code survivability of big mechanism is dismally low, because likely it's exsanguination, and there's not a great deal we can do with that in the short term. Look at your disability, get your GCS. Make sure your patient's not getting repetitive, because we know those symptomologies of subdural and epidural hematoma, where they're starting to get that waxing and waning mentation. So we want to keep somebody talking, and that's really kind of important as part of our assessment. And get these people moving, right? They have to go moving towards a trauma center, especially those with multi-system trauma. But if they meet criteria and they have a significant mechanism, and I kind of think a blast injury would almost always fit in that time frame, we certainly want to get them to the highest level of acuity possible. Get them to a trauma center. And remember, scene time, that's that platinum 10 minutes, right? And while I like platinum 10, golden hour, I believe in let's lower the clock, right? Let's expect the best of ourselves. Save seconds and cells. If you are maximally efficient and you didn't waste a second, you don't have to worry about these other benchmarks, because you got the person out as efficiently, safely, and fast as humanly as possible. And the second you think you have it perfect, do it faster, do it better, and do it safer. And you will consistently get better at what we do. Good sample OPQST, understanding that if somebody has a history of being anticoagulated, they're more likely to bleed. Understand that beta blockers can hide tachycardia. So their past medical history, even in trauma, absolutely counts. If the patient's going to lose consciousness, and this was the last attempt we had to make a med list, to get medical history, to find out when they ate last, to find out what they're allergic to, and now they're unconscious and you didn't get that stuff, shame on you, right? So we have to make sure that your next question is the next most highest priority. Don't show up to the trauma center and know your patient's, like, is a Gemini, like favorite color blue and likes long walks. We don't need that information. We know what we need. Secondary assessment, again, rechecking those lung sounds, rechecking your vital signs, making sure we're not missing that increasing tachycardia or falling blood pressures. Make sure we're not missing anything. It's about serial vital signs and serial assessments. looking for things that are going to change over time. After a few minutes and those natural endorphins have worn off on your patient, very often they may be reporting new complaints that need to be surveilled. So keep them talking, keep them telling you what's going on, and very often that's going to help you use your patient as a partner in their own assessment. Pulse, respirations, certainly auscultation of that blood pressure, very high. I really believe in getting a manual read at least once. I'm not against automation, but when it's very high or very low and we discount it, get a manual. If you intend to treat it or it's sentinel in your diagnostics, always get at least one manual to make sure that your machine is getting what it should. Physical exam, thorough physical exam prior to or during transport. I prefer get them out of there. Do that secondary exam on the way to the trauma center. That way, if you find something life-threatening or your patient digresses, you weren't waiting for that to happen. You were already on the way. Arrive with that finding. Don't arrive too late. Head to toe, systematic manner. And the systematic manner they're talking about is start at the head, work towards the toe. If you incrementally look at everything in 1-inch intervals from head to toe, you can't have done a bad exam. If you skip 5 inches, you miss some stuff, right? So don't do that. Head, neck, palpate. Visual. I felt it, I looked at it, and I auscultated it where appropriate. If you're not doing all three, you're missing parts of your exam and you're leaving stuff on the table, and we can't afford to. Ears, eyes, nose, throat, mouth, oropharynx, nasopharynx. Every inch you should have an assessment and a question and a finding, right? We get to the chin, neck, right? Nuchal rigidity. Is it stiff? Step-offs. Trachea's midline, no JVD, clavicles going across 1-inch sections. That's what we're checking for. And you must go, again, systemically across the chest. Let's palpate that abdomen, 4 quadrants. Let's ask about it. Look for the ecchymosis. We have to inspect it, auscultate it, and palpate it. If you're not doing all 3 of those, you're leaving a lot on the table. Palpate those legs and extremities, right? I like give me a big grip. Radial pulses. Feel me touching you here? Yes. Positive sensory circulation and motion. Upper extremities, palpate them, go to the bottom of the feet, push on the gas, pull back. I have distal pulses. Feel me touching you here? Yes. Palpate up the legs. We've done a complete exam, and we have CSM, sensory, circulation, and motor, times 4 extremities, and that's a good finding. And the patient's following commands the whole time and talking to you, which is also good. Repeat that primary and keep it going. If you have a patient that's all hands and they're super critical and all you can do is airway breathing and circulation and it's all hands to keep them alive, don't do a secondary exam to not save their life, right? It only becomes when and if necessary, when there's time permitting. Reevaluate those vital signs, review the status. If you gave them a little bit of fluid and you expected an outcome, check it. Oxygen didn't bring up SAT, check it. You got to look at those interventions and reassess that patient consistently. And I know what we say in the books, right? Q5 for unstable, Q15 for stable. You know what? It's Q every single minute of your patient contact because things don't change on some 5-minute time frame. Things digress right there in front of you. Get that GCS. Know your benchmarks, right? A little bit of confusion. We're at 14. We expect it to maybe get better. If it's getting worse, your patient's deteriorating. If it's less than 8, you got to consider that airway, and maybe we have to take over. Look for your respiratory rates, expansion. Big issue, right? Because pneumos progress. Bilateral pulmonary contusions progressively get worse, so all of those things are necessary. Cap refill, right? Under 2 seconds. It's a lost art. Let's start bringing it back. It tends to work out pretty well. GCS, a lot of trauma survivability, especially with neuro injury, comes down to what was their GCS initially? Did it digress? Did it improve over time? And very often, getting that early baseline is a good predictor as to what they're going to need first, right? Does the patient go directly to CT or they need that ultrasound first? Like, really, they're going to be able to prioritize what the patient needs off what we're telling them, off the priorities that have been identified typically in the field or from your story of the mechanism. Revised trauma score, it's a little bit convoluted, a little more difficult even than the Glasgow Coma Scale, but the RTS is used by the trauma centers. Less and less, it seems, because I think people are just doing it. Highest score is 12, lowest is a 0, and typically is scored for trauma survivability, essentially, and or what the priorities are going to be as far as what level they need. So again, it's built off your GCS score, first and foremost, and you get a maximum of your 3, and you get your points there. If you're 13 to 15, you get max points, you get your 4. If your systolic blood pressure is Typically, if you're 90 and above, you're going to get full credit there. Otherwise, you're going to lose points there based on your mentation, your systolic blood pressure, and how fast you're breathing. And it uses this as what most people will recognize as, hey, that's our triage criteria when we're doing START, right? Mentation, perfusion, and respiratory rate. And that's typically how it's built. And it's a good predictor as far as how they were triaged as to how they should do at the end. Stands to reason they would use that same revised trauma score. Management. During transport, begin your interventions. Don't be doing a lot on scene. The more interventions done on the scene of a patient with significant mechanism and bad trauma, the worse the outcome tends to be. PHCLS and ATLS American College of Surgeons have said it over and over and over. The thing they need most is a trauma surgeon and blood. Because you don't have either, what they need you to have is recognition and humility enough to know that we don't have those things. Get them moving. Keep them oxygenated, keep them warm, and keep them moving. Those are your biggest three priorities. And you'll find that all three of those are BLS skill sets. EMTs tend to save trauma patients. Medics, we will kill them if we get into a little too much paramedicine, a little less common sense, and EMTs, good skills. Consider fluid resuscitation. Kind of controversial. I think fluid in trauma is fantastic, unless the patient's bleeding on the inside and we can't stop it. In which case, we're just putting extra fluid into a tank with a leak. Seems like a bad idea. You're on the murder death squad. So permissive hypovolemia, or allowing their blood pressure to go pretty low, as long as you're mentating, the pressure's good enough. If I believe somebody's bleeding in the belly and they have an 82 blood pressure, but they're mentating, I'm not giving them extra fluid. I'm not going to rinse out the arteries. That pays homage to our funeral parlor days and not so much to good outcomes. So we have to be careful and smart with fluids. All trauma gets fluid? No. Many patients will die. If you have a closed head injury, you give them fluid, you're doing bad. If they're bleeding in their belly or chest and you give them fluid, you're probably doing it bad. If they're not mentating, you have no choice but to give them that fluid. But know that it's not going to be good for them. It's going to potentially, it means that their prognosis is quite poor. Hypothermia, very bad. We always talk about keep your trauma patients warm, but very often we don't put it in numerical context. 3 to 4 degrees of Fahrenheit lowered in your core body temp is actually the equivalent of like 5 mics per kilo of dopamine. And while you know you would never put somebody bleeding on the inside on dopamine, or a trauma patient on dopamine and squeeze out towards the hole, it would be killing them, we have to see cold as being contraindicated as well. Our trauma centers are kept like 90 degrees in those rooms, and not because that's comfortable. If you're not sweating profusely in the back of a truck, working diligently on a trauma patient, there's a good chance they're in an environment that's too cold. So got to have a hot box. Got to crank up the heat in the back of the truck for significant trauma patients. OB active labor, hot truck. Major trauma, you got to keep it warm, right? Because coagulopathic changes are going to take place when they're cold. They're going to be peripherally vasoconstricting, which is automatically worse, and the acidosis is going to feed into itself, in which case that's the triad of death. And we can keep a lot of that from happening with literally just creating a warm environment, keeping our patient covered up. We have to see it all, but we don't have to keep it naked. We can cover it up and keep it warm, right? And use that secondary surveillance. Let's be smart. We have to remain. The priorities are, one has to be keep them warm, and if we only have 3 or 4 big priorities, then certainly that there's no reason to have skipped any of them. GCS less than 13. Typically, you're going to go to a trauma center. If you're hypoperfused, you're going to go to a trauma center. You will be handed a list of red and or blue criteria for what is the state of Florida's trauma alert criteria system, and you're going to notice that they are typically associated with bad outcomes, right? Less than 10, greater than 30, right? That's our red for our triage criteria, and you can see it, that's how that works, right? Those 3 criteria of the rapid trauma score. Anatomic stuff, long bone fractures, 2 of them. If you're greater than 55, it can count. If you're crushed, mangled, if you have any chest wall instability, if you're tachypnic, if you're hypoperfused, all of those are reds, right? And the blues tend to be, there's paresthesias, there's numbness, tingling, that automatically gets you that visit to a trauma center by recommendation. Certainly not a rule, but a recommendation at that point. If you're greater than 55 and you fall down and you break that proximal femoral neck, well, you have a long bone fracture and you're greater than 55, that's 2 blues, that's a red criteria, but that doesn't necessarily mean that patient needs a trauma center. So it really comes down to good paramedic and or EMT judgment at that point as to who will benefit from being and have better outcomes from being in a trauma center, and that's who should go. Adults, I like the concept of just 3 times your height. 3 times your height almost always works, right? So children, if you're a child and you're 3 feet tall and you fall from 10 feet, it's more than 3 times your height, you go. But that 20 and 10 is depicted on state criteria as well as your textbook. High-risk auto crashes, where there's a big intrusion, a 3-foot intrusion in the front. You bent the steering wheel, you starred the windshield, there was a good speed. All of those things kind of count. If you're ejected from a vehicle, I don't care much what the car looks like. You left it not of your own volition, so obviously that counts. The things that, if I told you the story, you'd be like, ooh, that sounds like a bad outcome. These are things that count, right? If you're very young, very old, they count. Concomitant problems with medicine associated with your on anticoagulations. EMS provider judgments on the list for things that don't meet those criteria, but you go, you know what? I got a bad feeling about this based on XYZ, in which case I would prefer they go to a trauma center based on those things. You have that right. Paramedic discretion or paramedic judgment or EMS provider judgment is on the list for a reason, because it has saved lives. The American College of Surgeons, this is a committee on trauma, they have separate levels of trauma centers, level 1, level 2, level 3, and level 4. Typically level 1, the full Monty, right? They have it all. Early notification allows them to enact all of those amazing resources that they have to them. And the biggest key is, what is your capability and how quickly can you enact those services? And level 1, obviously, those people have residencies. They're typically teaching hospitals. Because they're residents, i.e. they live there, they're always available. All the specialties are available 24/7. That's the best you can get. But not just in the acute phase. Understand that systems are in place in these places for rehab, for healing, for everything they're going to need afterwards, and maximize these folks' outcome. We have level 1 trauma centers. We have level 2 trauma centers. Know what your demographic is, know what your first due is, know what the capabilities of these facilities are, and who should go there. And maybe more importantly, how they should get there. Fast is everything, right? Need blood, need a trauma surgeon. We know where they are, at the other end of where that thing lands, in which case the faster they're called, in it, and moving, the better outcomes they have. If you're greater than 30 minutes by ground to a level 1 trauma center for a trauma alert, this should be enacted. And that typically comes down to your policy and procedure of where you're employed. But typically, if you're on Orange Avenue, obviously you don't need a helicopter, you need a quick transport to a trauma center, right, to RMC in that case, in which case, reasonable time. Remember, these things are associated with weather, traffic, right? If you're on a vehicle accident and you got your road backed up for 15 minutes, or 15 miles rather, you know that's going to add time as far as ground transports in either way, in which case, all right, then this may be something you have to use. Whatever the fastest way to get a trauma alert to a trauma center is going to be your right choice. And get yourself a nice, safe landing zone, and make sure that the landing zone's attended by firefighter personnel, and it's kept secure and safe and surveilled, and make sure that we have our issues. Trauma centers greater than 20 to 25 miles, and/or a lot of protocols you'll see 30 minutes. That's your guideline. ALS ambulance, ground. If you can get them there faster, that's the right answer, right? Take them immediately. Time ticking is everything. Save seconds and cells. Maximal efficiency means maximally good outcomes. Criteria, typically medical use, traffic conditions, hospital availability. If we have a multi-system trauma patient and we have several of them and we've inundated a hospital, we may have to get a helicopter to take them to a trauma center further away in the same amount of time, because you've enacted air services. So criteria for operations is going to be a lot of time designated by your employers in the future or current. But what you really have to understand is, what is the priority for having my patient have the best outcome? And very often, in big trauma where there's multiple victims, we do have to spread the wealth a little bit so as not to inundate any one facility. EMS systems require that you be brought to the nearest hospital very often, in which case most MCIs are going to involve, your reds may fly if in fact they meet trauma alert criteria, but it really depends on the demographic, and that comes down into your MCI criteria. They're going to use that incident command system, and somebody's going to be able to make those decisions for you. But on a 2-person vehicle accident, you're the first to arrive. You have to be able to be on top of what does your patient need immediately. So they need you to make a quick transport decision first and foremost. And because you're making that transport decision quickly based on the mechanism, right? The first thing you see, and then the patient presentation, even that general impression, the first thing you see, it's very often you can make that trauma alert designation very, very early into the call, in which case there you just saved 3 minutes of indecision. That's the patient's 3 minutes that they make it to the OR and survive. So very important. Give the time for the aircraft to get there. You're going to have X number of minutes before they're going to arrive. That's you packaging, doing your primary assessment, doing those critical interventions that are going to sustain life. Get them where they need to be. Designate a team to the LZ. Make sure there's a command on this particular unit, because now you have two different sections, your scene operations and your LZ. Somebody's got to be talking to the aircraft coming in, making sure everybody's safe and on the same page. Good communication has good outcomes. Military, extensive research regarding trauma patients, pneumatic anti-shock garments, tourniquet use, lots of stuff, right? We're getting into evidence-based practice. And NAEMT is leading, along with the College of Surgeons, a lot of the science, saying, hey, these are the recommendations, this is why, based on science, not opinion, not because we've always done it that way. The old dinosaurs like myself, we grew up with trauma with put 2 lawn darts in and flood them. Well, that's no longer the recommendation because it didn't lead to better outcomes, and that's bad. We want the best outcomes for our patient long term, not just delivering 120 already to the hospital that doesn't have a prayer to survive because you flooded them, right? Fluid's good for the right patient at the right time, the right dose. Let's start treating fluid like it's a medicine, because it's a medicine. We're funny like that. We will complete here, trauma systems, mechanism of injury. Mike Hislop for Orlando Medical Institute TV, trauma, trauma, trauma.